It seems so simple, doesn't it? You get a cut, maybe a scrape, and, well, your body just sort of fixes it.
Hmm.
It closes up, it heals over time, maybe leaves a little mark. We see it constantly.
Yeah, every day.
But if you actually, look under the hood, what's happening there is anything but simple. It's incredibly complex, really dynamic.
Absolutely. It's this whole meticulously orchestrated biological process.
Hmm.
And understanding that process, you know, what goes right, what can go wrong, that's just
But
fundamental.
optional for what exactly?
Well, for so much in medicine, especially surgery, I mean, how we manage injuries, how we think about complications, planning treatments, it all really comes back to this basic science of tissue repair.
Right. And that's exactly what we're doing today. We're taking a really deep dive into wound healing, tissue repair, pulling apart the core concepts from the materials we've been studying.
Yeah, we're aiming to really unpack it all, look at the fundamental biology, how different tissues heal, differently, what messes things up,
How wounds get classified and managed.
and even tackle some of the really tricky stuff, like complex injuries and those chronic wounds that just won't heal.
Exactly. Our mission here is, frankly, ambitious. We want to go deep enough using these key insights that you can really grasp these concepts, understand all the nuances.
Basically, approach wound healing with the same kind of depth as the experts.
We want you to really master this information.
It's about building that solid mental model, isn't it?
Yeah.
Understanding the power, but also the limits of this process.
Okay, let's start that journey then. First up, the fundamental process. How does skin normally heal? It starts the instant you get hurt, right?
That's right. The absolute first step is hemostasis, the body's immediate reaction to stop the bleeding.
How does that work?
Well, when a blood vessel gets injured, its lining, the endothelium, is disrupted. That triggers two things right away. The vessel constricts, narrowing itself to limit blood flow, and the underlying matrix, the stuff beneath the lining, gets exposed.
And that exposure is like a signal.
Exactly. A signal flare for platelets floating by in the blood. They stick to that exposed matrix, they get activated, and they start clumping together really fast. That forms the initial platelet plug.
Like a temporary patch.
A very temporary patch, yeah. But these activated platelets, they do more than just clump. They release substances from tiny packets inside them called alpha granules.
Okay, what's in those?
Hundreds of different proteins, actually. But crucially, signaling molecule cytokines and growth factors. Things like TGF-beta, PDGF, FGF, EGF, VEGF. Really important stuff.
And what are those signals telling the body?
They're basically sending out the call for help. They attract other cells to the area that's chemotaxis. They start preparing the ground for rebuilding, laying down some matrix components. They signal for the skin surface cells to start migrating, epithelialization. And they trigger the growth of new blood vessels, angiogenesis.
Wow, so the platelets do way more than just plug the hole.
Oh, yeah. They're initiating the whole repair cascade, not just stopping the immediate bleeding. And at the same time, something else is happening.
The coagulation cascade.
Right. Triggered by something called tissue factor that also gets exposed. It's this complex chain reaction of enzymes.
That ultimately makes thrombin.
Exactly. And thrombin's main job is to take a soluble protein in the blood, fibrinogen, and convert it into insoluble fibrin strands.
Which forms the clot.
Yes. These fibrin strands weave themselves through and around the platelet plug, making it much stronger and more stable. Think of that adding reinforcing steel bars to concrete.
Okay.
And this fibrin mesh isn't just structural, it also creates a scaffold, a framework that other cells will use to crawl into the wound site as healing progresses. There's also a whole system, the fibrinolytic system, to break down this clot later when it's done its job. Factor 30 helps stabilize the fibrin too.
Got it. Bleeding stopped, signal sent, structure laid down. What's next? Inflammation.
Inflammation. And it overlaps with hemostasis, starting pretty quickly within hours. The early phase, maybe the first day or two, you see this huge influx of inflammatory cells.
Yeah.
First responders are the neutrophils?
Right, the body's sort of shock troops.
Kind of, yeah. Their main role here is fighting off any bacteria that got in, minimizing contamination, and doing some initial cleanup of debris. Also, the platelets and the injured tissue keep releasing things like histamine and serotonin.
Which make blood vessels leaky.
Precisely.
Yeah.
Increases vascular permeability. So more fluid, more proteins, and importantly, more inflammatory cells can get out of the vessels and into the wound tissue.
Okay.
Then around day 2 or 3, the next wave arrives. Monocytes.
And these turn into macrophages, right? The material suggests they're crucial.
Oh, they are absolutely vital. They are powerful phagocytes, eating up dead cells, bacteria, debris, using enzymes to bring stuff down. But maybe even more importantly, they become the main producers of the cytokines and growth factors that drive the transition from this cleanup phase to the rebuilding phase.
So they clean and they signal for the builders to come in.
Exactly. They stimulate the fibroblasts, the main building cells, to proliferate and get active, and they also push angiogenesis, the new blood vessel formation.
And this whole inflammatory phase, this is why wounds get red, swollen, hot, painful, the classic signs.
That's it. Rubor, tumor, Cowler, and Doler. That's inflammation in action.
Okay, site cleaned up, orchestrated for building. Next is proliferation.
Right. This usually kicks off around day 3, and it's characterized by intense activity focused on actually rebuilding the tissue. It can last, 2 to 4 weeks typically.
And the star player here is the fibroblast.
Fibroblasts are the workhorses, definitely. They migrate into that fibrin scaffold we talked about and start churning out 2 main things: ground substance, sort of the gel-like filler material, and collagen. Collagen is the key structural protein.
Gives the new tissue its strength.
Exactly. And at the same time, you've got angiogenesis happening in overdrive, building new capillaries to feed this very active tissue, and the skin cells at the edges, the epithelial cells, are migrating across the wound surface to cover it up. That's re-epithelialization.
That pink, kind of bumpy-looking tissue you see in a healing wound is that granulation tissue.
That's precisely what it is. It's this temporary matrix full of new blood vessels, fibroblasts, inflammatory cells. Looks granular. As proliferation continues, more and more collagen gets laid down, so the wound starts gaining tensile strength. And some of those fibroblasts change.
Change how?
They differentiate into myofibroblasts.
Myo meaning muscle, so they can contract.
Yes, they have contractile properties, and they play a really important role in wound contraction, physically pulling the edges of the wound closer together. This is especially significant in larger wounds that are left open.
So proliferation is about building, filling, and covering. Then the final phase? Remodeling.
This is the maturation phase. It starts overlapping with proliferation, maybe around week 2 or 3, but it'd go on for a year, even longer. The focus shifts from just adding bulk to refining and strengthening the new tissue.
And the big change is in the collagen.
Yes. The initial collagen laid down is mostly type 3, which is relatively weak and disorganized. During remodeling, this gets gradually broken down and replaced by type I collagen, which is much stronger and more organized.
Like upgrading the building materials.
That's a good analogy. The body tries to get back towards the normal skin ratio, which is mostly type I. The collagen fibers also get cross-linked more effectively and tend to align themselves along lines of stress.
Which makes the tissue stronger.
Much stronger. The tensile strength continues to increase significantly during this phase. The material suggests it reaches its peak around 12 weeks after the injury.
But even after all that, it doesn't get back to 100%.
No. Remarkably, the final strength of the healed scar tissue is only about 80% of the original uninjured skin. That scar tissue, which is the hallmark of adult healing, just never fully replicates the properties of the original tissue.
It's an amazing process, but just for skin, the body's full of different stuff. Do bones and nerves heal the same way?
The broad phases are similar in inflammation, building, remodeling, but the specifics, the cells involved, the outcomes, they can be quite different. The source material gives some great examples.
Let's look at bone healing. That seems like it would have to be different, being so rigid.
It is. Most broken bones, especially those managed without surgery, heal by forming a callus. This is called indirect or secondary bone healing. First, you get a hematoma, a blood clot at the fracture site that triggers inflammation. Then the hematoma gets replaced by a soft callus, which is mainly fibrocartilage. It sort of bridges the gap.
Like a temporary, flexible scaffold.
Kind of, yeah. Then this soft callus undergoes endochondral ossification, basically. The cartilage turns into bone, forming a hard callus of woven bone. This stabilizes the fracture. There's also some direct bone formation, intramembranous ossification, happening near the ends.
So the body builds its own internal splint.
Exactly, a bony splint. Then, over months, even years, this bulky woven bone callus gets remodeled. It's replaced by stronger, more organized lamellar bone, and the bone gradually reshapes itself back towards its original form.
What about primary bone healing? Sounds less common.
It is, naturally. Primary bone healing happens only when the broken ends are perfectly aligned and held absolutely still rigidly fixed, usually with surgical plates and screws. In this case, there's no significant callus. Bone forms directly across the fracture line, mainly by intramembranous ossification. It's faster, but requires that surgical stability.
That's the goal of surgery then, often.
Often, yes. But if you have a gap in secondary healing or it's not stable enough, that's when you can run into problems like delayed union, non-union where it just doesn't heal, or malunion, healing in the wrong position.
Fascinating. Okay, what about nerves? Peripheral nerves, can they regenerate if they're cut?
Peripheral nerves do have some capacity to regenerate after injury, but it's a really complex process, often incomplete, especially after a severe cut, what we call neuromesis.
What happens immediately?
Distal to the injury, the part disconnected from the nerve cell body, the axon and its myelin sheath break down and degenerate. This is called Wallerian degeneration, after Augustus Waller.
And the bit still attached?
That also degenerates back a short distance, usually to the nearest node of Ranvier, those gaps in the myelin sheath, named after Louis-Antoine Ranvier.
So a segment dies back. How does the growing end find its way?
The regenerating nerve fibers, sprouting from the proximal end, are guided towards the distal stump. It's partly chemical attraction neurotropism, mediated by growth factors, and partly physical guidance. The Schwann cells are key here.
They make the myelin, right?
In the peripheral nervous system, yes. After injury, they help clean up the debris by recruiting macrophages. Then they multiply and line up along the path the original nerve took, forming these structures called the bands of Bungner.
Like guide tubes.
Exactly. They create pathways that can guide the sprouting axons across the injury gap towards their target muscle or skin receptor.
So always work.
Unfortunately, no. If the gap is too large, or if there's significant scarring, or if the outer layer of the nerve bundle is damaged, the regenerating axons can get lost or tangled up. They can form a disorganized mass of nerve fibers and scar tissue called a neuroma, which can be really painful.
Ouch. Okay, one more tissue. Tendons. Tough, fibrous cords.
Tendons also follow the general healing pattern. The big challenge with tendons, though, is balancing healing with function. They need nutrients and cells to heal, but they also need to glide smoothly, often within a sheath.
How do they get nutrients?
Two main ways. Intrinsic healing relies on the tendon's own limited blood supply, often from small vessels called vincula, and nutrients diffusing from the synovial fluid within the sheath. Extrinsic healing involves cells and vessels growing in from the surrounding tissues, but this leads to adhesions.
Fibrous connections between the tendon and its surroundings.
Exactly. And those adhesions are bad news for movement. They stick the tendon down, limiting its glide and reducing range of motion.
So the goal is to promote intrinsic healing and minimize those adhesions.
Precisely. And a key strategy for achieving that, perhaps counterintuitively, is early, controlled active movement after the tendon has been surgically repaired.
Movement helps prevent sticking.
It does, but it's a very delicate balance. The repair is fragile initially.
So you need to protect it, but also move it.
It's critical. Repairs must be protected, usually with the splint, to prevent rupture. But specific, careful mobilization protocols are started early to encourage that intrinsic healing and keep adhesions from forming and maturing. It requires very careful management and patient compliance.
It's amazing how the strategy adapts. But of course, things don't always go to plan. Let's talk about abnormal healing.
Right. Many factors can throw a wrench in the works and disrupt this carefully orchestrated process. These are usually categorized as local factors, issues right at the wound site, and systemic factors, things affecting the patient's whole body.
Local factors like too much tension on the wound edges, or not enough oxygen, ischemia.
Exactly. Or poor blood supply in general, maybe from vascular disease, swelling, like lymphedema, contamination with dirt or bacteria, actual infection, leaving foreign bodies in the wound, or previous radiation therapy to the area.
These directly interfere with the cells doing their jobs.
Pretty much. They can starve cells of oxygen, create a hostile environment, or just overwhelm the repair process with persistent inflammation, like in an infection.
And systemic factors. Things like getting older.
Yeah, advancing age slows things down. Obesity, malnutrition, not having the protein and vitamins needed. Smoking is a big one, impairs oxygen delivery.
Underlying diseases too, like diabetes.
Diabetes is a major culprit. It affects blood vessels, nerve function, immune cells. Also, connective tissue diseases, being immunocompromised, maybe from HIV or medications.
What kind of medications?
Steroids are well known for suppressing inflammation, which you actually need early on. Immunosuppressants used after transplants, for example. Chemotherapy, drugs. Understanding all these potential negative influences is vital because you often have to address them to get a wound to heal.
You have to treat the patient, not just the wound.
That's the essence of it. Now, when healing goes wrong, you tend to see two main bad outcomes. Either the wound just fails to heal properly, becoming chronic, or you get excessive scar tissue formation.
Too much scar. Like
Yeah.
if the body overdoes the repair.
In a way, yes. It's often linked to prolonged or excessive inflammation, driving too much collagen production by the fibroblasts. The material distinguishes two main types: hypertrophic scars and keloid scars.
What's the difference there?
Hypertrophic scars are raised, often red and firm, definitely have excess collagen, but it tends to be somewhat organized in parallel bundles. The key thing is they stay within the boundaries of the original wound or incision.
And they might get better over time.
They often do. They tend to flatten and soften eventually. They're more common in areas with high skin tension or wounds that cross tension lines, or after deep burns that took a long time to heal.
Okay, and keloids.
Keloids are different beasts.
Yeah.
They also have excess collagen, but it's much more disorganized, forming thick, irregular bundles. The defining feature is that they grow beyond the original wound borders, invading the surrounding normal skin like a tumor, although they're benign.
And they don't get better on their own.
Generally, no. They tend to persist and are notoriously difficult to treat effectively. The exact cause isn't fully known, but there's a clear genetic predisposition. They're more common in people with darker skin pigmentation and can sometimes arise from very minor injuries like ear piercing or even spontaneously.
So hypertrophic stays in bounds, might improve. Keloid grows out, persistent, hard to treat.
That's a good summary. Knowing the difference is crucial for deciding on management.
Which leads us nicely into how clinicians actually categorize wounds and the different ways they can be closed or left to heal.
Right. There are terms describing the method of closure, sometimes called types of healing.
Like primary healing or healing by first intention.
That's the ideal scenario. It means the wound edges are brought together directly right after the injury, usually with stitches, staples, or glue. It works best for clean wounds with minimal tissue loss, where the edges come together easily without tension. Gives the fastest healing and the neatest scar.
Okay. Then secondary healing or second intention.
That's when you deliberately leave the wound open. It has to heal from the bottom up by forming granulation tissue. Then the wound contracts as those myofibroblasts work, and finally, the skin cells migrate in from the edges to cover it.
Takes longer, bigger scar.
Yes, much longer. More inflammation, more granulation, usually a less cosmetically appealing scar. It's necessary for heavily contaminated wounds, or where there's significant tissue missing, or maybe where primary closure would risk trapping infection.
And the third one, tertiary healing or delayed primary closure.
This is sort of a hybrid approach. You leave the wound open initially, maybe for a few days, perhaps because it was very dirty or you're worried about infection developing. You might clean it out surgically again. Then, once you're happy it looks clean and healthy, you go back and surgically close the edges.
Like a delayed primary closure.
Exactly. Giving it a chance to declare itself clean before closing.
So those are methods of closure. What about classifying the wounds themselves? Sounds complicated.
It can be, because wounds are so varied.
Right.
There's no single perfect system, so clinicians often use multiple descriptors. But a very widely used system, especially for surgical wounds, classifies them based on the expected level of bacterial contamination at the time of surgery.
Is this the clean, contaminated, dirty classification?
That's the one. Class 1, clean wounds. Elective surgery, no inflammation, didn't enter respiratory, GI, or GU tracts, low infection risk. Class 2, clean contaminated. Entered those tracts, but under controlled conditions, no unusual contamination. Think elective bowel surgery. Class 3, contaminated. This includes fresh accidental wounds, major breaks in sterile technique during surgery, gross spillage from the gut, or surgery in the presence of acute inflammation, but no pus. Class 4, dirty or infected. These are old traumatic wounds with dead tissue, or situations where there was already an existing infection or perforated bowel found during surgery. High infection risk.
That seems really practical for predicting infection risk after surgery.
It is. That's his main purpose. It helps guide decisions about antibiotics, for example. It's widely used, though sometimes deciding between classes can be a bit subjective.
Are there other classification systems?
Oh, yes. There are specific grading systems for pressure ulcers, diabetic foot ulcers, etc., and systems that try to combine wound factors with patient factors. The material mentions the NNIS score, the National Nosocomial Infection Surveillance Score.
What does that do?
It predicts the risk of surgical site infection by giving points based on 3 factors. 1, is the wound contaminated or dirty, class 3 or 4. 2, is the patient's overall health poor, using the ASA score, American Society of Anesthesiologists score of 3 or more. And 3, was the operation unusually long, longer than the 75th percentile for that type of procedure.
So it adds patient risk and procedure risk to the wound contamination risk.
Exactly. Gives a score from 0 to 3. Higher score means higher risk. Beyond that, you'll hear wounds described by their cause, like a surgical wound, a crush injury, a burn, a bite, by depth, epidermal, dermal, full thickness, by complexity, simple cut, versus involving tendons or bone, whether there are complications like necrosis or infection, or simply whether it's acute or chronic. You often need several terms to really describe a wound properly.
It definitely takes a detailed vocabulary. Okay, with all that background on processes, problems, and classification, let's get practical. How do clinicians actually manage a wound?
It always starts with assessment. Thorough assessment. You need the story. When did it happen? How did it happen? What forces were involved? Was it a clean knife or a dirty fall?
And assessing the patient too, right? Looking for those risk factors we talked about.
Absolutely crucial.
Right.
Are they diabetic? Do they smoke? Are they malnourished? On steroids? You need the whole picture. And importantly, you need to understand the patient's perspective, their ideas, concerns, expectations, and realistically, can they adhere to the treatment plan?
Makes sense.
In trauma situations, initial assessment follows standard protocols like ATLS, Advanced Trauma Life Support. You deal with life-threatening things first, then limb-threatening. Complex injuries often need a team, orthopedics, plastics, vascular surgeons working together.
Then you focus on the wound itself. Size, shape, depth.
Site, size, shape, yeah.
Yeah.
What does it look like? Is there obvious contamination, dirt, foreign bodies? Signs of infection, already redness spreading, pus, swelling? Is there pulsatile bleeding suggesting an artery is hit? Any deformity suggesting a fracture underneath? How much skin is lost? Can you see deeper structures like tendons or bone?
And you have to connect the appearance to how it happened.
Critically important, because sometimes a tiny wound on the surface hides massive damage underneath.
Like that high-pressure injection injury example.
The classic one, a pinprick entry from a grease gun or paint sprayer. But the material has been forced under high pressure deep along tissue planes. It causes huge mechanical disruption and chemical inflammation far from the entry site. It's a surgical emergency requiring urgent, wide exploration and debridement, or the limb might be lost. The outside look is completely deceptive.
Wow. A stark reminder.
Definitely. It also highlights why you need good pain relief before you start poking around in a wound, and why you should test sensation and muscle function before injecting local anesthetic if possible, so you don't mask a nerve or tendon injury. Imaging like x-rays can also be helpful to look for fractures or hidden foreign objects.
Okay, assessment done. What are the key principles for actually treating the wound?
The general principles are often summarized as preparation, dealing with the wound itself, achieving closure, and planning follow-up. Preparation includes things like making sure the patient has adequate pain control, checking their tetanus status, and giving prophylaxis if needed.
Tetanus is still a concern.
Absolutely. Any break in the skin carries a risk, especially certain types of wounds. We also consider antibiotic prophylaxis.
When are antibiotics given preventatively?
Generally for contaminated class 3 or dirty class 4 wounds, sometimes for clean contaminated class 2, and sometimes even for clean class 1 wounds if the consequences of an infection would be catastrophic, like putting in a heart valve or a joint replacement, or if the patient is very high risk.
And the tetanus shot, how do you decide who needs what?
It depends on two things. The patient's vaccination history, have they had a full primary course, when was their last booster, and the type of wound. Some wounds are considered tetanus prone.
Like what?
Puncture wounds, especially if contaminated with soil or manure. Bites, compound fractures, wounds with a lot of dead tissue, or burns, especially if there's sepsis. Wounds containing foreign bodies.
And there are high-risk tetanus-prone wounds too.
Yes, that's basically any tetanus-prone wound that also has heavy contamination, significant delay before treatment, more than 6 hours, or extensive devitalized tissue. Based on the history and the wound type, there's an algorithm to follow that tells you if they need just the vaccine or the vaccine plus tetanus immunoglobulin preformed antibodies, or maybe nothing if they're fully up to date and it's a clean wound.
Right, a standard protocol.
A central public health measure. Okay, so after preparation, you address the wound itself. The cornerstone here, especially for traumatic or contaminated wounds, is early and thorough debridement and irrigation.
Debridement, cutting away the dead stuff and contamination.
Exactly. It sounds simple, but it's arguably one of the most critical interventions, and its importance is often underappreciated. You have to remove all non-viable tissue that's dead or dying, and any foreign material. Deciding where dead tissue stops and healthy tissue begins can sometimes be tricky, especially in crush injuries or burns.
How can you tell?
You look for signs of viability. Healthy fat looks yellow and soft. Healthy muscle should be reddish, bleed when cut, and maybe twitch if stimulated. Skin edges should bleed. It often requires good judgment and experience.
And sometimes one go isn't enough.
Frequently, especially in really nasty wounds like blast injuries or necrotizing fasciitis. You might need planned second-look operations every day or two, taking the patient back to the operating room for further debridement until the wound bed looks entirely clean and healthy.
The material mentioned different types of debridement.
Yeah, several ways to do it. Surgical debridement is the gold standard for significant amounts of dead tissue, using scalpels, scissors, curettes, to physically excise it until you see healthy bleeding tissue. Mechanical debridement uses physical forces like high-pressure irrigation or the old-fashioned wet-to-dry dressings, which pull off debris but also healthy tissue.
Less selective.
Right. Autolytic debridement uses special dressings like hydrocolloids that keep the wound moist, allowing the body's own enzymes to naturally liquefy the necrotic tissue. It's selective, but slow. Enzymatic debridement uses topical ointments containing enzymes like collagenase to break down dead tissue chemically.
And the biological one?
Yes, maggot debridement therapy, using sterile medical-grade larvae, usually the green bottlefly, Lucilia sericata. They selectively consume necrotic tissue and bacteria and secrete substances that promote healing. Quite effective for certain types of chronic wounds.
Amazing. And irrigation is always important.
Yes, flushing the wound out, ideally as soon as possible. It mechanically removes loose debris and bacteria and helps you see what you're dealing with. Usually done with lots of warm, normal saline, though sometimes just tap water or dilute antiseptics are used. Maybe a soft brush for ingrained dirt.
Okay, so clean and debrided. Then you explore.
You need to systematically explore the wound to understand the full extent of the injury. Are deeper structures involved? Nerves, blood vessels, tendons. Has it gone into a joint? Is there an underlying fracture? You need to know exactly what's damaged. Requires careful handling of tissues.
And then repair what's damaged.
Once the wound is clean, yes, you repair injured structures. Nerves and blood vessels often require microsurgical techniques, using magnification like loupes or an operating microscope for precision.
Then finally, closure. The key principle was no tension.
Absolutely critical. Skin edges must come together without being stretched tight. If there's tension, the blood supply to the edges is compromised, the stitches can cut through, the wound can break down, or you get a wide, ugly scar. Direct closure isn't always possible if there's tissue loss.
That's where reconstruction comes in, the ladder or elevator idea.
Exactly. It's a way of thinking about the options, from simplest to most complex, to close a defect that can't just be stitched together. Though sometimes with modern techniques, you might jump straight to a more complex option if it's clearly the best solution.
What are the main options on that ladder?
Well, you start with primary closure if possible, then maybe secondary intention, letting it heal open, or tertiary, delayed primary closure. Then you get into things like negative pressure wound therapy, NPWT, skin grafts.
Split thickness or full thickness.
Right. Then maybe dermal substitute matrices, then local flaps using tissue right next to the wound, regional flaps from nearby but not adjacent, pedicled flaps, where the flap stays attached by its blood supply stalk initially.
Tissue expansion.
Tissue expansion, stretching nearby skin first, and at the top, free flaps transferring tissue completely with its own artery and vein and reconnecting them microsurgically at the recipient site.
What's the fundamental difference between a skin graft and a flap?
A skin graft is just a sheet of skin, epidermis and some or all of the dermis, that's completely detached from its blood supply. It's placed on a healthy, bleeding wound bed and has to survive by getting new blood vessels to grow into it from the bed. It's passive.
Relies entirely on the recipient site.
Totally. A flap, on the other hand, is a unit of tissue transferred with its own intrinsic blood supply. Whether it's kept attached by a pedicle or transferred freely and reconnected, its survival depends on its own vessels, not primarily on the recipient bed growing into it. It brings its own lifeline.
That makes sense. Flaps for poorly vascularized beds.
Often, yes. Or where you need bulk or need to cover exposed bone or tendon where a graft wouldn't take.
And negative pressure wound therapy. The wound vac.
NPWT has become a really common tool. Developed in the 90s, it involves applying a special foam dressing, sealing it with film, and connecting it to a pump that creates continuous or intermittent suction.
What does the suction do?
Several things. It helps pull the wound edges together mechanically. It removes excess fluid. It reduces swelling and edema. It seems to stimulate blood flow and the formation of granulation tissue. It can really help prepare a complex wound for definitive closure.
But it's not the final closure itself.
Generally not. It's an adjunct, a bridge to surgery, or sometimes used over grafts. And it has contraindications. You wouldn't use it directly over exposed blood vessels or nerves, or if there's malignancy in the wound or untreated bone infection, or lots of necrotic tissue still present.
Okay, that gives a great overview of the general toolkit. Now, let's dive into some of those specific, challenging acute wound types the material highlights. Bites, for instance.
Bites can be tricky. Most are puncture wounds or maybe avulsions tearing away. The really high-risk one highlighted is the fight bite.
A punch hitting someone's tooth?
Exactly. A clenched fist hits a tooth. The tooth penetrates the skin over the knuckle, usually the metacarpophalangeal MCP joint. You have to assume that the joint capsule has been breached and bacteria from the mouth have been inoculated directly into the joint.
Causing a septic joint.
Potentially, yes. And septic arthritis is a surgical emergency because the infection can rapidly destroy the joint cartilage, leading to permanent damage and stiffness. You need to look for signs like a hot, red, swollen, very tender joint with pain on even slight movement. Needs urgent washout in the operating room.
Okay, noted. Degloving injuries sound dramatic, too.
They are. Degloving means the skin and the underlying subcutaneous fat have been sheared off or torn away from the deeper fascia covering the muscles or bone.
Can it be internal?
Yes, it can be open, where you see the skin loss like a badly avulsed finger,
Ooh.
or it can be closed, where the skin surface might look intact or just bruised, but underneath it's detached from the deep layers. This often happens in high-energy shearing injuries, like being run over by a vehicle.
And the damage can be worse than it looks.
Much worse. In closed degloving, a large area of the detached skin flap may actually be non-viable because the blood supply running through the subcutaneous tissue has been disrupted. It's often hard to tell initially how much will survive.
Is that related to the Morel-Lavallée lesion?
Yes. A Morel-Lavallée lesion is a specific type of closed degloving injury, first described by the French surgeon Victor Morel-Lavallée over the hip area. It's where the shearing force creates a space between the subcutaneous fat and the deep fascia, and this space fills up with blood and lymph fluid because the small perforating vessels and lymphatics running between those layers have been torn. The term is now often used for similar collections elsewhere on the body, too.
How do you know how much of the degloved skin will survive?
It's notoriously difficult. You often need serial assessments, sometimes requiring trips back to the operating room for reevaluation and further debridement of areas that declare themselves non-viable over time. Signs of non-viability include the skin developing a fixed, bruised staining or visible thrombosis, clotting, in the small subcutaneous veins.
Are there tools to help assess?
Clinical judgment is key. Sometimes surgeons will do serial excision, trimming back the edges until they see good pinpoint dermal bleeding. There are also techniques using fluorescent dyes like intravenous fluorescein or indocyanine green, ICG, which light up under specific light sources if blood flow is present. Requires specialist equipment, though.
And there's a classification for these.
Yes, for degloving injuries associated with limb trauma, there's a classification system based on the pattern and severity from limited abrasion avulsion up to circumferential multiplanar degloving. It helps guide management, which for the most severe patterns might even involve considering primary amputation.
Gosh. Okay, moving to another limb-threatening emergency, acute compartment syndrome.
This is a condition where pressure builds up inside a closed anatomical compartment, typically the muscle groups in the lower leg or forearm, which are tightly wrapped in an elastic fascia.
And the pressure cuts off blood flow.
Exactly. Increased interstitial pressure within the compartment exceeds the pressure in the capillaries, compromising blood flow and oxygen delivery to the muscles and nerves trapped inside. If not relieved quickly, the tissues die.
Surgical emergency.
Absolutely. Delayed diagnosis leads to irreversible muscle death, necrosis, nerve damage, and potentially severe long-term disability, chronic pain, or even limb loss.
What usually causes it?
Most commonly follows fractures, both open and closed, especially the tibia and the lower leg. But it can also result from severe soft tissue crush injuries, burns, bleeding into a compartment after vascular injury, or even just prolonged compression like someone found unconscious lying on their limb.
What's the key sign to look for?
The cardinal symptom is pain that is out of proportion to the apparent injury. Severe, deep, aching, worsening pain. And crucially, pain that is significantly exacerbated by passive stretching of the muscles within the affected compartment. That's a huge red flag.
More pain than you'd expect.
Way more. Another important early sign is paresthesia, numbness, tingling, pins and needles, indicating nerve dysfunction due to ischemia. Late signs like absent pulses or paralysis are bad news, meaning significant damage has likely already occurred. Absence of pulses is actually uncommon, usually suggests a major arterial injury in addition to compartment syndrome.
Diagnosis is mainly clinical.
Primarily clinical, based on high index of suspicion and these key symptoms, especially the pain profile. It can be difficult in patients who are unconscious, multiply injured, have nerve blocks, or in young children. In uncertain cases, you can directly measure the pressure inside the compartments using a special needle and pressure monitor.
Is there a pressure threshold?
Various thresholds are used, but a common guide is that the difference between the patient's diastolic blood pressure and the measured intracompartmental pressure, ICP, should be more than 30 mmHg. If it's less than 30 mmHg, i.e. the compartment pressure is getting close to the diastolic pressure, that's highly suggestive and usually warrants intervention.
And the intervention is fasciotomy.
Yes. Urgent surgical decompression by making long incisions through the skin and, critically, through the overlying deep fascia to open up all the affected compartments, relieving the pressure.
And the muscle bulges out.
If the pressure was significantly elevated, yes, the muscle often visibly bulges through the fascial opening once it's released. In the lower leg, you typically need 2 main incisions to reliably decompress all 4 compartments.
What if it's diagnosed late?
That's a real dilemma. Performing a fasciotomy on muscle that is already dead or dying carries very high risks of severe infection, systemic illness from muscle breakdown products, rhabdomyolysis, potentially leading to amputation or even death. It becomes a very complex and dangerous situation.
Okay, one more devastating acute condition. Necrotizing fasciitis.
Yes, sometimes sensationally called flesh-eating bacteria, though that's not quite accurate. It's a severe, incredibly rapidly progressing infection, primarily involving the soft tissue layers down to and including the deep fascia.
And it's deadly.
It has significant morbidity and mortality. The material quotes studies showing 30-day mortality up to 26%, and 1-year mortality up to 40%. It's a true surgical emergency.
What causes it?
It's often polymicrobial, meaning multiple different types of bacteria working together synergistically, but it can also be caused by a single aggressive organism, classically group A Streptococcus, Streptococcus pyogenes. Other common culprits include Staphylococcus aureus, various gram-negatives like E. coli or Pseudomonas, and anaerobes like Clostridium or Bacteroides.
How does it usually start?
Often there's some initiating event, like minor trauma, a cut, an insect bite, or recent surgery, allowing bacteria to get into the deeper tissues. However, sometimes no clear entry point is found. Certain comorbidities increase risk, diabetes being the most common, but up to 30% of patients might have no significant underlying health problems.
What are the warning signs? Again, pain.
Pain is usually the earliest and most prominent symptom, and again, it's often described as pain out of proportion to the visible skin findings. The skin itself might initially just look red, erythema, swollen, edema, and feel warm, maybe mimicking simple cellulitis.
But it progresses rapidly.
Very rapidly. Other signs develop, sometimes crepitus, a crackling sensation under the skin due to gas produced by bacteria, blisters or bly forming, maybe a dusky skin discoloration, a grayish, watery, foul-smelling discharge, often called dishwater pus. Eventually, you see frank skin necrosis or gangrene. Systemically, patients are usually very unwell fever, rapid heart rate, rapid breathing, signs of shock, confusion, potentially multi-organ failure.
So severe pain, rapidly changing skin, systemic illness. Diagnosis is clinical.
Primarily clinical. High index of suspicion is paramount. There are scoring systems based on lab results, but their reliability is debated. The absolute rule is surgical treatment should not be delayed if there's a strong clinical suspicion. Waiting for imaging or definitive lab results can be fatal.
And the treatment.
Immediate resuscitation, broad-spectrum intravenous antibiotics covering the likely organisms, and urgent, aggressive surgical debridement. This means cutting away all infected and necrotic fascia and overlying tissue until you reach healthy bleeding tissue. It often requires very extensive excisions.
And usually needs repeat surgeries.
Almost always. Patients typically need planned second-look operations within 24-48 hours and often multiple further debridements until the infection is fully controlled and the wound bed is clean. It's a devastating condition requiring intensive care and multiple surgeries.
These acute conditions really highlight the fragility underlying the repair process. What about the other side of abnormal healing wounds that just fail to heal? Chronic wounds.
Right. Chronic wounds are essentially wounds that get stuck. They fail to proceed through the normal, orderly phases of healing in a timely fashion. They often get stalled in the inflammatory phase.
Characterized by that prolonged inflammation.
Yes, persistent inflammation, often persistent low-grade infection or colonization by bacteria, impaired cell function, an imbalance of enzymes that break down tissue versus build it up. The whole process is derailed.
How do you manage those differently?
The core principles involve identifying and, if possible, correcting the underlying reason why the wound isn't healing.
Yeah.
Is there poor blood flow? Is there uncontrolled diabetes? Is there unrelieved pressure? You also need to manage the wound bed itself, debriding any necrotic tissue using any of the methods we discussed, controlling infection or bacterial burden, managing exudate, and choosing dressings that create an optimal environment, often managing moisture balance.
And chronic wounds often fall into specific categories.
Commonly, yes. The big three are vascular ulcers caused by either poor arterial inflow, arterial ulcers, or faulty venous outflow, venous ulcers, or a mix. Diabetic ulcers typically on the feet, related to nerve damage, neuropathy, poor circulation, and structural changes. And pressure ulcers, or pressure injuries.
Leg ulcers seem particularly common.
They are the most common type of chronic wound in developed countries. An ulcer is just defined as a break in the continuity of the epithelium, the skin surface. Chronic ulcers often develop that characteristic appearance, maybe some necrotic tissue or slough in the base, often surrounded by a rim of thickened, fibrotic, inactive-looking tissue because the prolonged inflammation leads to abnormal scarring at the edges.
What causes most leg ulcers?
The vast majority, probably 70–80%, are due to venous disease, chronic venous insufficiency. Arterial disease accounts for maybe 10–15% and a mix for another portion. But there are many other potential causes too: trauma, persistent infections, bacterial, fungal, even things like TB or syphilis, metabolic disorders like gout or calciphylaxis, autoimmune conditions like vasculitis or scleroderma, blood disorders, and importantly, cancer.
Cancer again. A skin cancer presenting as a non-healing ulcer.
Yes, it's a crucial differential diagnosis. Any chronic ulcer, particularly one that looks unusual or just isn't responding to appropriate treatment over several weeks or months, must be considered for biopsy to rule out malignancy. Most commonly, squamous cell carcinoma, arising in a chronic wound or old scar. That's the Marjolin's ulcer we mentioned earlier, named after Jean-Nicolas Marjolin. But basal cell carcinoma or even melanoma can sometimes present this way.
So the lesson is, don't just keep putting dressings on a leg ulcer that isn't healing. Find out why.
Absolutely. You need to diagnose the underlying cause, assess the arterial circulation, palpate pulses, measure ankle brachial pressure index, assess the venous system clinically, maybe with ultrasound, check sensation, especially for diabetic neuropathy. Treatment has to target the cause: compression therapy for venous ulcers, revascularization for arterial ulcers, glucose control for diabetes, etc. Surgery is usually a secondary option if conservative measures fail.
Okay. What about pressure ulcers, now often called pressure injuries?
Yes, the terminology shifted to pressure injury by groups like the U.S. National Pressure Injury Advisory Panel, NPIAP, because injury can occur to underlying tissues even before the skin breaks down. They result from prolonged pressure, usually over a bony prominence like the sacrum, heels, hips, or under a medical device, which cuts off blood flow to the tissues. Shear forces often contribute.
And there's a staging system.
Yes, the NPIAP system is widely used. Stage 1, intact skin with non-blanchable redness. Stage 2, partial thickness skin loss, like a blister or shallow crater involving epidermis and neurodermis. Stage 3, full thickness skin loss. Subcutaneous fat may be visible, but not bone, tendon, or muscle. Stage 4, full thickness skin and tissue loss, with exposed bone, tendon, or muscle. Stage 4, there's also unstageable, where the base is obscured by slow or Escher, and deep tissue injury. Intact skin with persistent deep red, maroon, or purple discoloration, indicating damage underneath.
And the key message is that these should be preventable.
Largely, yes, they are a major indicator of quality of care. Patients most at risk are those with limited mobility, impaired sensation, severe illness, poor nutrition, and incontinence. Common sites are the sacrum, heels, ischial tuberosity, sitting bones, greater trochanters, hips, elbows, back of the head.
So prevention is paramount. How?
It starts with risk assessment using validated tools, the Braden scale, the Waterlow score, Norton scale, named after their developers, then implementing preventative strategies. Regular skin inspection, meticulous skin care, frequent repositioning, turning schedules, usually every 2 to 4 hours, using specialized pressure redistributing support surfaces, mattresses, cushions, optimizing nutrition and hydration, and educating patients and caregivers.
And if one develops despite prevention?
Treatment focuses on optimizing the patient first, managing medical conditions, improving nutrition. Continuing all the preventative measures is crucial to stop it worsening or recurring. Debridement of any necrotic tissue is usually necessary. Appropriate dressings are chosen to manage exudate and provide a moist healing environment. Antibiotics are used only if there are clear signs of clinical infection, not just colonization.
Is surgery often used?
Surgery is generally not first line for pressure injuries.
Mm.
It's considered only after a concerted effort with non-operative measures has failed, and usually only in patients who are medically stable, well-nourished, and motivated enough to comply with the demanding post-operative care, which involves strict pressure offloading.
And what kind of surgery?
Simple closure or skin grafting usually fails due to the poor quality of the surrounding tissue and the underlying pressure issue. Reconstruction typically requires robust flaps, often large fasciocutaneous or musculocutaneous flaps that bring their own healthy tissue and blood supply to fill the defect and provide durable coverage. Careful planning is needed to preserve future flap options if the ulcer recurs, which sadly is common.
Right, bringing in that reliable blood supply again. Okay, we've covered the whole journey from injury to healing, or failure to heal. The end result of normal healing is, of course, the scar.
Yes, scar formation is the natural outcome of the remodeling phase. Initially, an immature scar is often quite active. It looks pink or red, feels firm or hard, might be raised, and is often itchy.
But it changes over time.
It does. As the collagen matures and remodels and the number of cells, fibroblasts, and blood vessels decreases, the scar gradually becomes paler, softer, or flatter, and usually less symptomatic. This maturation process takes a long time. Most changes happen in the first few months, but it can continue for a year, 2 years, or even longer.
And the strength improves, but plateaus around 80%.
That's right. Now, while some scarring is inevitable, there are established ways to manage problematic scars. Ones that are hypertrophic, keloid, contracted, or just cosmetically unacceptable. Evidence-based options include pressure therapy, like garments, silicone gel sheeting or ointments, intralesional injections, usually corticosteroids, and surgical revision.
Other things are used too.
Yes, things like therapeutic massage, sometimes psychological support for appearance concerns, laser therapy, radiotherapy, especially for keloids after surgery, cryosurgery, freezing, and other types of injections are also used, though the evidence base varies.
But prevention is better than cure.
Absolutely. The best scar results from optimal initial wound management and meticulous surgical technique.
Like planning incisions.
Yes, placing surgical incisions along natural relaxed skin tension lines where possible. Avoiding straight-line incisions across flexion creases, like elbows or knees, where they're prone to contracting or thickening. Handling tissues gently. Achieving meticulous haemostasis. Early debridement of traumatic wounds to reduce contamination and allow earlier closure.
And cleaning wounds properly, like scrubbing out dirt to prevent those traumatic tattoos.
Exactly. A basic step with a big impact on the final look. Also, carefully aligning anatomical landmarks, like the border of the lip, the vermilion border, during closure is critical.
And the closure itself, no tension.
No tension is key, allowing for some post-operative swelling. Using layered closure for deeper wounds closing the fascia, then deep dermal sutures, absorbable stitches within the dermis, to take tension off the skin edges, before closing the skin itself.
Does the type of skin suture matter?
Using fine monofilament sutures, placed carefully, and removing them at the right time helps minimize stitch marks. Subcuticular sutures, running just beneath the surface, avoid surface marks altogether. Removal time varies. By location, face sutures might come out around 5 days, while lower leg sutures might stay in for 10-14 days due to slower healing and higher tension.
Anything you can do after the stitches are out?
Yes, measures like applying supportive tape along the scar for a few weeks can help reduce tension. Keeping the scar well hydrated with simple emollients, and protecting it diligently from sun exposure, using high SPF sunscreen, for at least the first year is really important, as UV rays can cause hyperpigmentation and potentially worsen scarring.
What about managing those specific difficult scars, hypertrophic and keloid? Silicone first.
Silicone sheeting or gel is widely accepted as a first-line approach, both for preventing and treating hypertrophic and early keloid scars. It seems to work by hydrating the scar tissue and modulating fibroblast activity.
And if that's not enough for a hypertrophic scar?
The next steps might involve pressure garments, laser therapy, like pulse dye laser or fractional laser, or intralesional corticosteroid injections, like triamcinolone. Sometimes combinations are used. Surgery is an option, but needs careful planning to address underlying tension if possible.
And for keloids, they sound much tougher.
They're notoriously difficult. Intralesional corticosteroids are often tried first, sometimes combined with other agents like fluorouracil. Laser can be used. Surgical excision is an option, but only if combined with adjuvant therapy immediately afterwards to prevent recurrence, which is very common and often worse.
Adjuvant therapy like.
More steroid injections into the wound bed at closure, silicone sheeting started early, pressure therapy, or sometimes even low-dose radiotherapy delivered soon after surgery. Other therapies like cryotherapy or injections of drugs like bleomycin are also used, but recurrence remains a major challenge. You absolutely have to counsel patients about the high risk of the keloid coming back.
Right. It's managing expectations. Lastly, contractures, scars that tighten and restrict movement.
Scar contractures can cause significant functional and aesthetic problems. When a scar crosses a joint or forms in an area like the neck or eyelids, the natural tendency of scar tissue to shorten during maturation can pull tissues together, restricting range of motion, leading to deformities, and impairing function.
What causes them? Just the scar shrinking.
It's partly the intrinsic contraction of the scar tissue itself, driven by myofibroblasts during remodeling. It can also result from a difference in growth patterns. The scar doesn't grow or stretch like the surrounding healthy skin, especially problematic in children.
Can they be treated?
Yes, surgical release of the contracture followed by reconstruction is often very effective. The basic principle is to cut through or remove the tight band of scar tissue, restore full range of motion, and then fill the resulting defect with healthy, pliable tissue.
What kind of reconstruction?
A wide range of options from the reconstructive ladder can be used, but typically involves either skin grafts or flaps. For linear contractures across joints, local flaps like a Z-plasty are very common.
What does a Z-plasty do?
It's a technique where you make a Z-shaped incision centered on the scar line, creating two triangular flaps. You then transpose these flaps, switching their positions. This cleverly breaks up the straight line of the scar, lengthens the line of contracture, and changes its direction, releasing the tension. There are variations like YV or VY plasties too.
And flaps are generally preferred over grafts for contractures.
Often, yes, because skin grafts themselves, especially split-thickness grafts, tend to contract as they heal, which can lead to recurrence of the contracture. If you need to cover a larger area after release, flaps bring their own supple tissue. If grafts have to be used, full-thickness grafts are generally preferred over split-thickness because they contract less and provide better texture match.
Wow. We have covered an immense amount of ground, from the body's immediate response to injury, through that incredibly complex dance of cells and signals during repair.
Exploring the pitfalls of abnormal healing, both acute emergencies and chronic failures.
And following the story right through to the long-term consequences, like scars and contractures. It really is an astonishing biological system.
It truly is. It highlights the body's amazing capabilities, but also its limitations, especially in adult healing, where the priority seems to be rapid closure, often at the expense of perfect regeneration, leading to that ubiquitous scar tissue. Really mastering this depth of understanding is just so fundamental for anyone involved in patient care.
It makes you look at even a simple healing cut completely differently, and it really brings that final thought into focus, doesn't it? We touched on how fetal tissue early in gestation can heal without scarring, perfectly regenerating.
Yeah, the potential is there.
So if regeneration is possible, why does adult healing almost always default to fibrosis and scar formation? And maybe more importantly, with all the advanced science we've discussed, understanding growth factors, cells, matrices, how close are we really to unlocking that potential, to maybe guiding adult tissues to heal more like they did in the womb?
That's the multi-billion-dollar question, isn't it? The implications would be staggering for burns, chronic wounds, fibrosis in organs like the liver or heart. It's a huge frontier in regenerative medicine, trying to bridge that gap between repair and true regeneration.
A really fascinating place to leave it. Thank you for joining us on this incredibly detailed deep dive into the world of wound healing and tissue repair.